Welcome to the deep dive. You're tuning in for a really focused session today, specifically designed to get you up to speed on cryoglobulinemia for your MSRA revision.
That's right. Think of this as your, high-yield summary. We're taking what can seem like a pretty complex topic and boiling it down to the essentials you need.
Exactly. We're using your revision notes as our guide here.
Yeah.
Our mission really is just to pull out that critical information about cryoglobulinemia that you need for the MSRA and, make it stick.
Yeah, medical terms can be, let's face it, a bit dense sometimes. So we'll unpack it, highlight the key points for understanding, and crucially for recall.
Okay, let's dive right in then. To start us off, what exactly is cryoglobulinemia? Can you define that for us?
Simply put, it's when you have these abnormal proteins called cryoglobulins in your blood. And the problem is they can lead to inflammation and damage to your blood vessels.
Okay, abnormal proteins causing vessel damage.
Right. And what's really key to understand from the outset is that this usually isn't happening on its own. It's often a sign, a sort of red flag for an underlying condition.
Like what kind of conditions?
Things like autoimmune diseases or certain infections, that link is really important.
Got it. So more of a symptom than a disease itself in many cases.
Pretty much. Now, to really get a handle on it, you need to know about Brouet's classification. It helps break it down into three main types, which is useful for thinking about causes.
Okay, classifications. Let's get into those. What's type I?
So type I accounts for about 25% of cases. The key here is that the cryoglobulins are monoclonal.
Monoclonal.
Meaning they're all identical copies of one type of antibody, usually IgG or IgM. And a good memory tip here, think M for monoclonal, M for myeloma or macroglobulinemia. Those are the conditions it's often linked with.
Oh, okay. M for monoclonal, M for myeloma macroglobulinemia.
Nice. What about type 2?
Type 2 is also about 25%. This one's different because it's mixed monoclonal and polyclonal antibody.
Yeah, so you've got one type of identical antibody, but also a bunch of different ones. These often include rheumatoid factor activity, which is important. And the big associations here are hepatitis C, rheumatoid arthritis, Sjögren's, and lymphoma.
Quite a few links there. Any memory tip?
You could think 2 is mixed, like two different types, monoclonal and polyclonal, mixing together. Or type 2, a duo of antibody types.
Okay, 2 is mixed or a duo, linked to Hep C, RA, Sjögren's lymphoma. Got it. And the last one, type 3.
Type 3 is the most common, actually, making up about 50% of cases. Here, the cryoglobulins are purely polyclonal.
So just a variety of different antibodies.
Exactly. And again, these usually involve rheumatoid factor. The common links here are rheumatoid arthritis and Sjögren's syndrome, those common autoimmune conditions.
Right. So maybe think 3 is polyclonal, often linked to common autoimmune issues.
Perfect. That works well. So you see how the classification helps point towards potential underlying issues.
Definitely. So regardless of the type, what's the main damage mechanism? What do these cryoglobulins actually do?
Well, the critical thing is that these proteins can clump together, forming what we call immune complexes.
Okay.
And these complexes then get deposited in the walls of blood vessels. This deposition triggers inflammation, that's the vasculitis we mentioned, and that inflammation can damage the vessels and organs by, messing up blood flow.
Right, the inflammation and poor blood flow causing the problems.
Yeah.
And are there classic symptoms we should look out for?
Yes, there's a sort of classic triad often mentioned. Pupia, that's the skin rash, often palpable, purplish spots, weakness, and arthralgias, which is just joint pain.
Purpura, weakness, arthralgia.
Exactly. A simple way to remember it is PWA, purple, weak, aching. If you see that combo, cryoglobulinemia should definitely be on your differential.
PWA, purple, weak, aching. Easy enough. Okay, now let's dig into the causes, the etiology. What's driving the production of these abnormal proteins?
Well, as we hinted, underlying autoimmune disorders are really common culprits. Think systemic lupus erythematosus, SLE, or rheumatoid arthritis. It's like the immune system gets confused and starts making these problematic proteins.
So the immune system attacking itself in a way.
Kind of, yeah. But arguably the most significant trigger, especially for the mixed types, type 2 and 3, is hepatitis C virus infection. HCV plays a massive role.
HCV. Right, definitely need to remember that one. Are there other causes besides autoimmune conditions and Hep C?
Yes, though they're less common. Certain cancers, other chronic infections besides HCV, and even some medications have been linked to it. But the key takeaway for your revision is that in, over 90% of cases, there's a known identifiable underlying cause.
Over 90%. Wow. So finding that root cause is crucial. I think the notes mentioned something specific about HCV, skin issues, and treatment.
Yes, good point. Mixed cryoglobulinemia is actually the most common dermatological or skin manifestation of HCV infection. And unfortunately, having cryoglobulinemia can sometimes make the hepatitis C infection itself harder to treat effectively. It complicates things.
Okay, so it's a common skin sign of HCV and can impact HCV treatment.
Exactly. And just to add one more infectious link from the notes, hepatitis E infection has also been associated with mixed cryoglobulinemia.
Hepatitis C as well, right?
Yeah.
So investigation for underlying causes, especially infections like HCV and autoimmune diseases, is absolutely key. What about risk factors then? Who's more likely to get this?
Well, number one risk factor, as we've stressed, is definitely hepatitis C infection. Beyond that, it tends to be more common in older individuals, and there's a slight female predominance. Women seem to get it a bit more often than men.
Okay, older age, female sex.
And logically, if you already have an autoimmune disease or another chronic infection, your risk is higher too.
That makes sense. Okay, let's shift to the pathophysiology. How exactly do these cryoglobulins cause trouble? You mentioned clumping.
Yes, the absolute core mechanism is their unusual property.
Hmm.
They precipitate or sort of solidify and clump together at lower temperatures.
So they're sensitive to cold.
Exactly. When blood flows to cooler parts of the body, like fingers and toes, these proteins start to aggregate, forming those amine complexes we talked about. These complexes then stick to the inside walls of small blood vessels. This deposition is what kicks off the inflammatory cascade, the vasculitis, leading to vessel damage and reduced blood flow to tissues.
So it's a temperature-triggered chain reaction.
Pretty much. We understand that precipitation and deposition part fairly well, but the precise molecular details of exactly how that deposition leads to the tissue damage downstream,
Right.
well, that's still not fully understood, still an area of research.
Okay, but the key is cold leads to clumping. Clumping leads to inflammation and blocked flow.
Hmm.
Now, if a patient comes in with symptoms, what else could it be? What's on the differential diagnosis list?
Right, this is crucial. You definitely need to consider other autoimmune diseases that can present similarly SLE, rheumatoid arthritis again. Other types of vasculitis are important too, things like polyarteritis nodosa or granulomatosis with polyangiitis.
Or vasculitis, okay.
And of course, don't forget other infections besides Hep C, HIV, hepatitis B, even hepatitis A need to be ruled out. Basically, anything causing systemic inflammation or vascular issues.
The notes had quite a long list of specifics for the differential, didn't they?
They did. It's worth having a broad awareness. Things like antiphospholipid syndrome, certain blood cancers like chronic lymphocytic leukemia, non-Hodgkin's lymphoma, multiple myeloma, Waldenström's, also conditions like cirrhosis, various types of glomerulonephritis, good pastures, HUS, sarcoidosis.
Wow, okay.
Yeah, it's a lot. The main memory tip is just to think broadly. Conditions causing systemic inflammation or vascular problems overlap significantly.
That's a good way to frame it. Let's talk numbers. How common is this condition? What's the epidemiology?
Okay, so in the UK specifically, the exact numbers aren't really well defined, but it's generally considered rare. It seems to be more common in areas where hepatitis C is more prevalent.
That makes sense given the strong link. What about worldwide?
Globally, mixed cryoglobulinemia types 2 and 3 affects roughly 1 in 100,000 people. There seems to be a higher prevalence noted in Southern Europe.
Interesting geographical variation.
Yeah. And the typical age when people present is usually between 40 and 60. We mentioned the female-to-male ratio earlier. It's about 3 to 1, so women are affected more often. And hammering the point home, HCV causes over 90% of those mixed cryoglobulinemia cases.
Okay, rare overall, more in high HCV areas, middle age, more women, huge HCV link. Got it. So what are the clinical features? What might you actually see in a patient?
The presentation can be really varied, but some features are very common. Skin signs are often prominent, that palpable purpura we mentioned, levator reticularis, which is that kind of net-like skin pattern, sometimes ulcers, or even gangrene in severe cases.
That was seen as a big one.
Definitely. Joint pain, arthralgia, and joint swelling are also very common. Peripheral neuropathy is another key feature, numbness, tingling, pain, often in the hands and feet.
Skin, joints, nerves. Sounds like a pattern emerging.
Absolutely. Kidney involvement is also significant. Yeah. You might see protein or blood in the urine, or tests might show reduced kidney function.
Get renal issues too, right?
And then there are more general symptoms. Fatigue, weakness, maybe weight loss. Raynaud's phenomenon, where fingers and toes change color with cold, can be a feature too. And obviously, if it is linked to Hep C, you might see hepatitis symptoms like jaundice, but often the HCV itself is asymptomatic.
Do the different types I, 2, and 3 tend to look different clinically?
They can, yes. Type I, the monoclonal one, often presents with more signs related to blood viscosity and flow problems. Things like acrocyanosis, that's the bluish tinge to extremities, retinal hemorrhage, really severe Raynaud's, and sometimes even arterial thrombosis, blood clots in arteries.
Okay, so type I is more about blocked vessels.
Kind of, yeah. Whereas types 2 and 3, the mixed and polyclonal ones, often share features like the arthralgias, the joint swelling, immune complex kidney disease, glomerulonephritis, those purpuric skin lesions, and various other skin issues from purpura up to ulcers.
So more overlap between 2 and 3 with skin, joints, kidneys. The notes had a useful frequency list, didn't they?
Yes, that's helpful for prioritizing. Skin symptoms, purpura, necrosis, ulcers are the most common presenting feature. After that comes joint disease, then renal disease, then Raynaud's.
Skin, joints, kidneys, Raynaud's.
Then neurological symptoms like neuropathy, followed by less common things like abdominal pain, sickta, symptoms, dry eyes and mouth. Acrocyanosis, hemorrhage, and finally arterial thrombosis and facial swelling are relatively infrequent initial signs.
So the memory tip, skin, joints, kidneys, covers the big 3 initial presentations. That's useful. Okay, so you suspect it based on these features. What investigations do you order?
Right. The absolute key first step is specific blood tests to actually detect and quantify the cryoglobulins. This requires careful sample handling, keeping the blood warm until the serum is separated because they precipitate in the cold.
Special handling, crucial point.
Very crucial. Alongside that, you'll run tests looking for those underlying causes, autoimmune markers, infectious screens, particularly for HCV antibodies and viral load, especially if you suspect mixed cryoglobulinemia. Liver function tests are also standard.
Okay, tests for cryoglobulins, tests for causes, HCV, check LFTs. What else?
You'll often check complement levels. C4 is typically low in types 2 and 3. ESR, a general inflammation marker, is usually high. Rheumatoid factor is often positive in types 2 and 3.
Low C4, high ESR, positive RFN3.
Correct. If there are skin lesions, a skin biopsy looking for vasculitis can be very helpful. A full blood count might show anemia or a high white cell count. Urinalysis and U&Es assess kidney involvement.
Kidney tests.
Yep, ANA if you suspect SLE. And serum and urine electrophoresis can pick up a monoclonal protein, especially relevant for type Y, pointing towards myeloma or Waldenström's. Remember, anti-HCV antibodies are positive in about 90% of mixed cases.
So a whole battery of tests, really, to confirm, classify, and find the cause?
Exactly. The diagnosis of mixed cryoglobulinemia syndrome really rests on having typical organ involvement plus finding those circulating cryoglobulins. Then you investigate further based on what you suspect is driving it.
Okay, comprehensive workup. Once you have the diagnosis, how do you manage it?
Management really hinges on two main things. Treat the underlying cause whenever possible, and manage the symptoms and organ damage from the cryoglobulinemia itself. The specific approach depends heavily on the type, the severity, and which organs are involved.
And I guess avoiding cold is key.
Absolutely fundamental. That's general advice for everyone with cryoglobulinemia. Avoid cold environments to minimize precipitation.
Makes sense. What about medications?
For milder symptoms like joint pain or fatigue, NSAIDs might be enough, but if there's significant organ involvement like kidney disease or severe neuropathy or skin ulcers, then you usually need immunosuppression.
Like steroids.
Corticosteroids are often used initially, yes. Sometimes stronger agents like cyclophosphamide or azathioprine are needed. But you have to be cautious, especially if there's an underlying infection like HCV, as suppressing the immune system too much could worsen the infection.
Right, a balancing act. What about specifically for HCV-related cases?
For HCV-MC, treating the hepatitis C itself is paramount. Modern direct-acting antiviral therapies are very effective and often lead to improvement or even resolution of the cryoglobulinemia. Sometimes ribavirin is added.
So treating the virus treats the cryo.
Often, yes. In severe cases, though, you might need immunosuppression alongside or before the antiviral treatment to get the vasculitis under control quickly. Plasma exchange, physically removing the cryoglobulins from the blood, can be used in very severe acute situations, too.
Plasma exchange. Okay.
Yeah.
And rituximab was mentioned.
Yes, rituximab targets B cells, the immune cells that produce antibodies. It can be very effective in refractory cases of mixed cryoglobulinemia syndrome, especially those with significant organ involvement that haven't responded to other treatments.
So a tailored approach. Avoid cold, treat the cause, especially HCV, use NSAIDs for mild symptoms, immunosuppression for severe cases, carefully, maybe plasma exchange or rituximab for tough situations.
That sums it up well.
What about the long term? What's the prognosis like?
It's really variable. It depends hugely on that underlying cause and how much organ damage has occurred. The good news is that timely treatment generally improves symptoms and can prevent complications.
And for HCV cases?
If the HCV can be successfully treated with antivirals, the cryoglobulinemia can often go into remission, which is obviously a great outcome.
That's encouraging. But overall,
Overall, the course varies. Prognosis is definitely worse if there's significant systemic involvement and severe organ damage, especially kidneys, heart, or the central nervous system. For HCV-positive patients, specific poor prognostic factors include severe liver fibrosis and that CNS, kidney, or heart involvement.
so early diagnosis and management are key to preventing that severe organ damage. Finally, what are the main complications we need to be aware of?
The big ones relate directly to that organ damage from vasculitis. Skin problems like ulcers or gangrene, kidney damage potentially leading to kidney failure, nerve damage causing neuropathy, and vascular issues that could lead to ischemic events like stroke.
Organ damage is number one.
Definitely. Also, because of the immune dysfunction itself or the immunosuppressive treatments used, there's an increased risk of infections. And there's a known increased risk of developing certain cancers, particularly non-Hodgkin lymphoma.
Increased infection and lymphoma risk.
Yes. And of course, you can get complications from the treatments themselves, especially the side effects of long-term immunosuppression.
Right. Okay, so to quickly recap for everyone revising, cryoglobulinemia involves cold-sensitive abnormal proteins causing vasculitis. Remember, PWA, purple, weak, aching.
Remember Brouet's classification. Type I, monoclonal, myeloma Waldenström's think M. Type 2, mixed, Hep C RA, Sjögren's think 2 is mixed. Type 3, polyclonal RA, Sjögren's most common.
Now, that huge link, especially for mixed types, is hepatitis C over 90% of cases. Always look for the underlying cause.
Clinically, think skin, joints, kidneys as the most common initial systems involved. Investigations focus on detecting cryoglobulins, handle sample correctly, finding the cause, HCV testing, and assessing organ damage, complements, ESR, RF, biopsy if needed.
Management, avoid cold, treat the underlying cause, especially HCV with antivirals, use NSAIDs or immunosuppressants depending on severity, consider plasmid exchange or rituximab for severe refractory cases.
Exactly. Understanding these key points, definition, causes, features, investigation, management, is crucial for your MSRA. Prognosis varies, but early treatment helps, and complications include organ damage, infection, and lymphoma risk.
Perfect. We really hope this deep dive has helped solidify cryoglobulinemia for your revision. For more practice questions and resources, do check out pastthemsra.com and also freemsra.com.
And maybe final thought, cryoglobulinemia is just a fantastic example of that complex interplay between the immune system, infections, and autoimmune processes, leading to systemic disease, a really core concept in medicine.